Hello everyone. In this video, we are going to continue the disorders of gastrointestinal system. That is, one of the topic is ascites in the children. Most common short note is asked as about the neonatal ascites, and also about the discuss as other short note as discuss the etiology and management of the ascites in the children. So these are the usual questions regarding the ascites in the ascites topic. So about the definition of the ascites, as we already know that the ascites, which means there will be abnormal pathological fluid accumulation within the peritoneal cavity. So abnormal pathological fluid collection within the peritoneal cavity is called as the ascites. Then about the etiology, it varies with age. That is, the in the case of neonatal ascites and also in the case of childhood ascites, the etiology is different. In the case of neonatal ascites, with the hydrops, that is with hydrops vitalis, these are the, if there is any presence of hydrops vitalis along with the ascites, these are the causes. That is, there will be different system involvement will be there. That is renal, we have the posterior urethral valve, congenital nephrotic syndrome is caused for the neonatal ascites with the hydrops. Then in cardiac disease like hypoplastic left heart syndrome and congenital uh, congenital heart disease in the case of the cardiac disease with the hydros vitalis in the case of neonatal ascites, and in the genetic syndromes like Down syndrome, then hematological like alpha thalassemia and GIT like intestinal atresia. So these are the causes for the neonatal ascites with the hydrops. And if the neonatal ascites without hydrops, only the neonatal ascites will be present. The reasons are bacterial peritonitis, chylous ascites, and urinary ascites. So these are the causes in the case or etiology in the case of the neonatal ascites. But in the case of the childhood ascites, there will be childhood ascites with the portal hypertension or without the portal hypertension. With the portal hypertension, there will be intrahepatic and extrahepatic causes. In the intrahepatic causes for the portal hypertension is that biliary tract, extrahepatic biliary atresia, cystic fibrosis, hepatocellular like hepatitis B, C, autoimmune hepatitis, Wilson disease, and alpha-1 antitrypsin deficiency. Then also toxins like methotrexate is the cause for the intrahepatic portal hypertension with the childhood ascites. Then we have the extrahepatic causes like venous obstruction, like splenic vein thrombosis, portal vein thrombosis, and Budd-Chiari syndrome. Then we have the childhood ascites without the portal hypertension, and these are the causes like infections like a TB, bacterial peritonitis, then HIV, then malignancies like peritoneal carcinoma, hepatocellular carcinoma, then about the hypoalbuminemia, then the nephrotic syndrome, protein losing enteropathy, and severe acute malnutrition with anasarca. Then miscellaneous causes like chylous ascites, bile ascites, and pancreatic ascites are there with the childhood ascites without a portal tension. These are the causes. So the etiology of these neonatal ascites with the hydrops and without hydrops, and the childhood ascites with the portal hypertension without a portal hypertension should be kept in mind. Then about the clinical features of the abdominal distension. The ascites causes the abdominal distension. The major clinical feature is like abdominal distension. The signs are the general. We have the signs like it is looks like a Spider-Man look, thin limbs with the protuberant abdomen, and genital edema will be the weight gain because of this ascitic fluid accumulation, and everted umbilicus will be the specific signs like the first sign appear is the puddle sign. And the Padelsine, for the Padelsine to positive, about 200 ml of the fluid is should be collected in the peritoneal cavity. Then second is horseshoe sign. There will be for 500 to 1000 ml of the fluid should be there. And second is the shifting dullness. 1000 ml is fluid is required. And about third is the fluid thread greater than 1000 or 1500 ml of the fluid is there for the manifestation of fluid thrill. Then absence of shifting dullness of fluid thrill does not rule out ascites. The signs of secondary effects like pleural effusion on the right side due to the defects in the diaphragm is also there. So that is all about the clinical features of the ascites. Then about the diagnosis, we have to go for abdominal parasynthesis. Ascitic fluid aspiration is the gold standard method for the diagnosis of ascites, and also to rule out the causes for the ascites. Then ascitic fluid interpretation. If the ascitic fluid is straw colored with the cobweb appearance, it is TB, and the straw colored with the transparent appearance, it is cirrhosis, and milky, it is chylous, and bloody, it is in the case of tuberculosis, malignancy, trauma, and pancreatitis. And the cell count, mainly lymphocytes, it is normal. less than 250, and greater than 250 cells per ml, predominantly polymorphs is indicator of the infected or bacterial. Then mainly malignant cells, which is indicative of the malignant ascites. Then we have to check for the proteins, that is serum ascites albumin gradient ratio, we should be assessed by the protein, by the abdominal tapping. That it has 97 to 98% of accuracy to differentiate between the portal hypertension and non-portal hypertension ascites. That is, in the non-portal hypertension ascites, the SAG value is less than 1.1. But in the case of portal hypertension ascites, SAG value is greater than 1.1 gram. Then for the easy interpretation of the SAG, the portal hypertension with the normal liver have the total ascitic fluid protein greater than 2.5, very high, and SAG value is greater than 1.5 gram, and the conditions are congestive cardiac failure and Budd-Chiari syndrome. And the portal hypertension with the altered liver function, the total ascitic fluid protein is low, and SAG value is very high, and the conditions like cirrhosis and chronic hepatitis. If there is no portal hypertension, the SAG value is the total ascitic fluid value is high, but the SAG value is low. Only in the case of hypertension, portal hypertension, there will be SAG values high. And that is conditions like TB, pancreatitis, chylous ascites, and malignant cells. No portal hypertension, there will be also the total ascitic fluid protein and SAG is also low. That is indicative of the nephrotic syndrome. Then after doing the abdominal paracentesis, we have to go for the radiological investigation in ascites. That is, we have to go for USG abdomen. It is very sensitive and pick up the minimum ascites. That is 50 ml of the blood ascites can be picked up by the USG abdomen, which confirms the portal hypertension. If the spleen is greater than 12 centimeter with a tortuous splenic vein, blocked portal vein, that is indicative of the portal hypertension. Detect the etiology, that is TB, bacterial peptide can be detected by the USG abdomen. Then also we have to go for another imaging modalities like CT abdomen. It is as sensitive as USG plus picks up cirrhosis of the liver and mass, etc. No needed routinely. So CT abdomen is not needed routinely, but USG abdomen have to be done routinely. Then for the management of the ascites part, it is also asked as a short note. Low SAG ascites, the treatment of the cause is required. Example, in the case of TB ascites, we have to go for anti-tubercular therapy, and in the case of nephrotic syndrome, we have to go for the steroids. The spontaneous resolution of the surgery in the pancreatic ascites. And in the case of treatment of the high SAG ascites, that is, we divide this treatment into log SAG ascites and high SAG ascites. Log SAG high ascites, we treat the cause. But in the case of the treatment of the high SAG ascites, that is portal hypertension with the altered liver function, we have to advise the diet, that is sodium restriction is the mainstay of treatment. In the infants, less than 1 gram per day. In the children, 2 to 3 milliequal per kilogram per day. Avoid snacks with the salt, example chips, pickles, and adding sweet to food helps sodium restriction. Then avoid spicy fried food. It precipitates variceal bleed, and fluid restriction only if the serum sodium is less than 120 milliequivalent per liter. And we have the supplementation of calories like 150 gram per day, 150 calorie per day. Then along with the advice to the diet, we have to go for diuretics. Indications, tense ascites, no response to sodium restriction. These are the indication for the administration of diuretics. And the drug of choice is spironolactone. That is potassium sparing diuretics. Dose is 1 to 3 milligram per kilogram per day in 3 divided doses. And the disadvantage is there will be less potent than furosemide, and it is low onset of action. And furosemide is a loop diuretic. Dose is 1 to 2 milligram per kilogram per dose. Maximum is 6 milligram per kilogram. Side effects like hypokalemia, hyponatremia, hepatic encephalopathy, hypovolemic shock. So that is all regarding the diuretic therapy. We have to monitoring a patient on diuretic therapy. That is daily we have to monitor for the weight, abdominal girth, sensorium, input to output chart, 24-hour urinary sodium, serum potassium, serum creatinine, and every 2 to 3 days we have to go for the ascitic fluid volume on the USG. So if the patient is on the diuretics, we have to monitor the patient by these methods. Then, so if if there is refractory ascites, that is ascites not responding to dietary sodium restriction, high dose diuretics is called the refractory ascites. The treatment options for the refractory ascites that are large volume paracentesis, that is, it is a cheap and easy and safe method. We get a temporary relief. and the maximum 5 liter in the children can be removed in 1 hour with IV salt-free albumin 6 gram per liter can be removed. And another is the tips. The second line improvement in the ascites greater than 1 to 2 months, and peritoneovenous shunt should be done in the case of refractory ascites, and also liver transplant. Last life-saving resort is the liver transplant if there is a refractory ascites. So that is all regarding the neonatal ascites and also the ascites in the children. Then next topic is on the Wilson disease. It is also as a short note. So it is an inborn error of metabolism that is characterized by the toxic accumulation of copper, mainly in the liver, brain, and cornea. And the prevalence is about 1 in 50,000, a leading etiology of the chronic liver disease in the children. That is, most of the chronic liver disease in children is contributed by this Wilson disease. So it is an accumulation of the toxic accumulation of copper, mainly in the liver, brain, and cornea. And the clinical features, which have the huge variety of the clinical presentation, age is usually occurs at 4 to 6 years of age. The common presentation in the childhood are there will be presentation in the like chronic liver disease. There will be firm to hard liver as features. Jaundice and ascites will be the age of diagnosis is 7 to 8 years. Then we have the presentation like acute hepatitis, that is which mimics the viral hepatitis, and we'll have the fulminant hepatic failure presentation. We have the will be stomachic cause. Then in the asymptomatic sibling or hepatomegaly, the features is like as of hepatomegaly. Neurological, we have scholastic deterioration, clumsiness, speech difficulty, choreoathetoid movements and seizures. And rarely knock-knees will be the rickets presentation will be there because of the vitamin D activation, lack of vitamin D activation. There will be rickets features also. There will be acute hemolysis will be there that results in the jaundice. Then what are the investigation we have to go for in the case of the Wilson disease? The serum ceruloplasmin is decreased because certain mutation which results in the defect in the transport protein, and this transport protein is essential for the conversion of the apoceruloplasmin to ceruloplasmin, and if there is absence of this transport protein which results in the decreased production of ceruloplasmin, so the ceruloplasmin is decreased, and it is a good screening test but not diagnostic. 24-hour urine copper excretion should be assessed. It is a better predictor of Wilson, that is it should be greater than 100 microgram per day. Hepatic copper by the biopsy should be assessed. It is a simple best predictor. Greater than 250 microgram per day is a diagnostic. Then this is the practical approach to Wilson disease. That is, if there is any hepatic presentation, any two of these, that is like decreased ceruloplasmin, increased urinary copper, and Kiesel-Fleischer ring is present, it is confirmed by the hepatic copper or start empirical chelation treatment. And the neurological presentation, if the patient is present with the neurological presentation in the case of Wilson disease, we have to look out the Kiesel-Fleischer ring positive in the almost all the cases. So we have to confirm it as the Wilson disease. Treatment about the we have to advise a diet regarding the diet, that is advise to avoid high copper diet like liver, chocolates, nuts, and dry fruits. Avoid copper or brass utensils in the kitchen, and the drugs which are usually used are the chelators, zinc, and ammonium tetrathiomolybdate, and the chelators are usually D-penicillamine and the trientine. D-penicillamine we have to give 10 milligram per kilogram per day 1 hour before meal in 2 to 3 divided doses. And the trientine we have to it has less side effects, and it is have to give the dose in the dose of 25 to milligram per kilogram per day. And zinc we have to supplement the zinc also because it increases the fecal copper excretion, so it is administered. Then ammonium tetramolybdate, it is not available at the present, so it is not used now. Usually now it is used is the chelators like a D-penicillamine, trientine, and also zinc. Then the treatment is lifelong but has variable outcome. Hepatic presentation which may show complete reversal. If there is neurological presentation which may leave the residual handicap, example speech, handwriting, etc. Death is also have been reported in the case of the Wilson disease. So that is all regarding the disorders of GIT. Thank you.